Welcome back to 10-minute radiology case reviews with Dr. Benjamin W. Strong.
Welcome to the vRad Trauma CT lecture on epidural hemorrhage. This is your host, Dr. Benjamin Strong. We'll be reviewing 5 cases of epidural hemorrhage, first on static CT images, on which the findings will be identified by colored arrow and listed in matching colored text. That will be followed by a cine review with similar annotations. Our first case is of epidural hemorrhage with pending uncal herniation. This hemorrhage is first visible in the lateral floor of the middle cranial fossa. Here you see an extra-axial lentiform hyperdense mass consistent with an acute epidural hemorrhage related to injury of the middle meningeal artery. Note the deformity of the underlying temporal lobe and the associated medial displacement of the uncus, which you see here distorting the suprasellar cistern. Here there is medial uncus displacement, obliterating the left aspect of the prepontine cistern, and here it is seen slightly deforming the adjacent left cerebral peduncle. There is an important additional finding, that of a dilated, deformed, elevated, and medially displaced inferior horn of the left lateral ventricle, which can be an important indicator of the presence of mass effect. Here's the extra-axial lentiform hyperdense mass consistent with acute arterial epidural hemorrhage. Here are views of the medial displacement of the uncus and of the dilated inferior horn. This patient has a non-displaced, barely visible fracture of the squamous portion of the petrous bone, a typical location. A magnified view shows this to be nearly as invisible. Epidural hemorrhages are almost all associated with skull fractures, and if you are unable to identify one, it most likely is because you lack multiplanar reformats or sufficiently thin sections. So that is the classic appearance of an acute arterial epidural hemorrhage related to injury to the middle meningeal artery. The medial displacement of the uncus suggests impending herniation, and you should have noted that this patient is in a very narrow treatment window. Our next case is a hyperacute epidural hemorrhage. This case differs from the previous in that this hemorrhage is more posterior, it is less lentiform in shape, and it is heterogeneous. It is its heterogeneity that specifically suggests its hyperacute time course. This patient also has dilation and deformity of the inferior horn. Note again the heterogeneity of this bleed, which suggests its hyperacute time course. And here again is the dilated, deformed inferior horn. This patient's skull fracture is very slightly displaced and is more visible by virtue of the overlying soft tissue swelling. So that is a hyperacute epidural hemorrhage. Our next case is of mixed venous and arterial epidural hemorrhage. This is the venous component in a typical location overlying the temporal pole. This is due to injury to the adjacent sphenoparietal sinus. This patient also has an arterial hyperdense epidural hemorrhage located more superiorly. There is the venous component, which differs in density from the adjacent hyperdense arterial epidural hemorrhage. The skull fracture in this case is as you might expect. It extends from anterior inferior to posterior superior and is in a distribution capable of injuring both vascular structures. So that is a case of mixed venous and arterial epidural hemorrhage. These venous epidural hemorrhages at the temporal pole can in isolation be managed without surgical intervention if they are sufficiently small and causing sufficiently little mass effect. Our next case is a frontal venous epidural hemorrhage, which you see here, slightly hyperdense and bridging the frontal midline. As a general rule, epidural hemorrhages do not cross suture lines, but the one exception to that rule is this, the frontal venous epidural hemorrhage. This is related to injury to the anterior aspect of the superior sagittal sinus. These hemorrhages can hide near the vertex and sometimes require the use of coronal reformatted images for identification. Here is the associated skull fracture, which extends from the right frontal sinus and terminates as a diastatic frontal suture. So that is a frontal venous epidural hemorrhage bridging the frontal midline. Our last case is a posterior venous epidural hemorrhage. This is related to injury to the transverse sinus and, as you can see, respects the midline as previously discussed. There is significant mass effect, as you can see reflected in this anterior displacement of the calcified choroid plexus of the left lateral ventricular atrium. There are significant infratentorial and supratentorial components to this bleed, as you would expect given its origin in the injured transverse sinus. Note also the pronounced mass effect in the left frontal cerebral convexities. And here is the non-displaced occipital fracture related to this injury. And that is a case of a posterior venous epidural hemorrhage related to transverse sinus injury. And that concludes our lecture on epidural hemorrhage. This is what you saw. Thanks for watching the vRad Trauma CT lecture series. This is Dr. Benjamin Strong, the host of 10-Minute Radiology Reviews. In the course of my career, I have worked as an internist, an emergency room physician, and an MR fellowship-trained radiologist. I'm currently the Chief Medical Officer of Virtual Radiologic, or vRad, the nation's largest and leading teleradiology practice. With over 500 emergency teleradiologists and serving over 2,000 client facilities worldwide, we have access to an extraordinary amount of educational content which you see in these presentations. If you like what you've seen, please feel free to share, comment, subscribe, or for that matter, join the nation's leading teleradiology practice.